And one more case was actually with HELLP syndrome, 39 years, surprisingly gravida 5, para 5, live child 1, and then 3 abortions. And with coagulopathy and AKI, she came to us and then was having breathlessness, high blood pressures, and low urine output at the time of admission. I think this case was discussed enormously. 3 conditions were overlapping in this. Emergency LSS was done under general anesthesia. All the lines were placed, including dialysis cath, and developed PPH, bilateral return artery embolization done, dialysis started for AKA, appropriate blood product transfusion was given, and in this, whatever the possible consultations to be given, whatever the possible assessments to be done, we did, and mainly obstetric gynec and medical gastro, interventional radiology, critical care, and anesthesia role was a small time, maybe 1 or 2 hours in this case, but anesthetist played a good role to keep the patient hemodynamically stable and shift to ICU and handing over to CCM people, and got discharged on 10th POD in stable condition. And one more case, 36-weeker, G2P1L1, partial HELLP syndrome, DAC, AKI, hepatopathy, and fibrinogenemia. For this case, actually, our critical care people, they sought hematologist consultation also, and he was also very actively involving in this case, and also managed with good amount of blood and blood products. But unfortunately, patient developed a trally, and there, for the diagnosis purpose and also for to rule out many lung conditions, pulmonologists were also involved in this case, and patient was kept on non-invasive ventilation and got discharged on 9th post-operative day. And 30-year-old primary 37-weeker, diagnosed to have supraventricular tachycardia in the 2nd trimester. She was kept on metoprolol 25 milligrams, admitted for institutional safe delivery. ECG showed multiple premature ventricular beats, bigeminy and trigeminy, and beta blocker was continued, and also some anxiolytics were given day before taking surgery, and elective LSS under simple spinal anesthesia was done, but we placed one arterial line to monitor her beat to beat BP monitoring. It was uneventful, and shifted to ICU for observation 24 hours for any arrhythmias or episodes of SVT under cardiologist supervision, and got discharged on 3rd POD without any episodes of SVT, and on the day of discharge the ECG was absolutely normal, and she was advised to continue metoprolol 25 milligrams till further orders. And 38-weeker primary 32-year-old, Marfan Syndrome, aortic arch aneurysm was there, no other comorbid conditions, and she wanted to have a safe institutional delivery, and she came to us. In this case, actually, we need to cut down the sympathetic tone, and patient should not have a strain, and there should not be major hemodynamic changes during the surgery or actually in real life also. And she opted for, and she was asking for, I should not have any pain after the surgery. Okay, we gave the option of both general anesthesia and combined spinal epidural. She opted for combined spinal epidural, and then combined spinal epidural was started, activated under local anesthesia, local anesthetics, and then surgery was uneventful. The surgery we did, the OT beside the cardiac OT in the 4th floor in this hospital, and where we were kept ready, everything, cardiopulmonary bypass, surgical team and anesthesia team, especially for this patient, till this surgery is done. And post-op, she was very much happy in the post-operative period because of the epidural infusions, and she got discharged on 3rd POD, and again reviewed within a week with the CT surgeon and also our obstetrician. And after all these 7 icebergs, I haven't gone any detail into any case, please. Whatever I have spoken, whatever words came out, they are all practical. No guidelines are involved. Please remember, thinking about the patient, assessment of the patient, collaborating, coordinating with each other departments, timely call up, saved many patients. Please. That's what our Kola Sahab also telling. Our case, your case, it's my case, it's your case. In these days, it's not possible. Maybe 30 years ago, 40 years ago, might have been possible at that time. But now it is our case, our team is managing this case. Having one of the best teams and team approach, our institute excelled in managing very, very difficult and bad cases. It's out of the contest, I can say one thing. Nikhil sir was telling, in the last week, we did the 85-year-old, one patient, 92-year-old, one patient. Interventional radiology. He was telling, both went home nicely, sir. See, that is the care we took here, basically. I am very much proud to work in institute like this. And the perspective of multidisciplinary approach is obvious in managing high-risk pregnancies, that is all the departments, particularly OBG, pediatrics obviously, cardiology, neurology, medical and surgical gastro, pulmonology, interventional radiology, hematology, blood bank, and particularly the backup, critical care medicine. If I don't understand anything going wrong on table, I am ready to pick up my phone and call either Ravi Shankar or Venkat Sahab. Because Venkat Kola Sahab may be busy, but definitely I will be calling Ravi or any one of the CCM fellow. Or at least I will inform that this is what happening on table, patient will come to ICU, kindly take care. And last but not least, our anesthesia team. Thank you very much.